Hello, my name is Glyn Elwyn, and thank you for the invitation to your conference in Porto. I wish I was with you, but here I am in what they call mud season in New England, in the United States. I'm here to talk to you about what I believe is the huge potential of shared decision making. However, I just want to say, I think there's a huge potential if done exceptionally well. So who am I? Well, I'm a professor here at Dartmouth. I was a family doctor in the UK before I came here, in Cardiff in fact. And I now work here in the Dartmouth Institute, which is part of the Dartmouth College. Here's my Twitter handle if some of you want to follow along with some of the work that I talk about on shared decision making. I want to mention some financial interests. I've been working for these organizations, and now I have a relationship with EBSCO Health, who are now producing option grids and where I have a consultancy. When I talk about shared decision making, I often use this cartoon. And I ask people to fill the speech bubble. And I would like to ask you now to imagine what's being said in this speech bubble. The answers I get are often certain things like, well, take this medication, or here's my diagnosis for you, or follow this advice. Where, in other words, they're putting the person with the spectacles, who maybe looks a little bit like me, in the clinician's seat. But then I show the next slide and say, well, no. This is the patient. And this patient has been given enough information by the female doctor here to be able to say, I prefer this option. He's been comparing alternative ways of managing his problem. And in a nutshell, this is shared decision making. It's really about helping a person develop an informed preference. Here's a more academic kind of definition. It's an approach where you're working together, using the best available evidence, and that's important. And here's a critical other issue. The clinician is supporting the patients to arrive at that informed preference. It's not something patients feel comfortable unless you're really supporting them to do that. It is not about making patients decide, giving them all the decisional responsibility, nor is it about giving patients what they want without any bar at all. We have a professional responsibility as clinicians not to do that. And certainly it's not evidence-free medicine. When do we do this? Well, I think we do it when patient views are relevant, and I think that happens to be most of healthcare, where patients have views about what's best for them and where patient-relevant factors exist about risk and harm, benefits and trade-offs. Why would we do this? Well, some people might say, oh, it's just the right thing to do, the ethical imperative. And actually that's a very, very good reason for doing shared decision making. But there are also other benefits. More satisfied patients, better informed patients. We have evidence that this is the case. Also, increasingly evidence that patients stick with their medicines a bit better if they understand really why they're taking them. Lower costs, yes, in some situations where there are very high cost issues, and it's particularly true in some situations in the USA. Less complaints, less litigations, and many organizations want this to happen, where better communication about treatment options, about the harms, means that patients are more immune to regret. They don't complain so much, say, well, I knew this might happen. So I want to tell you a story about Joseph. Joseph is a 55-year-old man with 3 children, and he's got angina, and he's struggling with it. And his cardiologist says, I can do a stent for you next week. And actually Joseph's belief was, yeah, if I have a stent, I'll have a lower risk of heart attacks in the future. That was a strong belief. And of course he wanted to reduce his angina. But things didn't go very well. He died from a pulmonary embolus 3 days after the operation, and his widow is seeking legal advice. So, reasonable decision, but disaster. What if Joseph had been in this situation where he'd been given some options? You could take optimal medication for your angina, or we can go for stenting. And he might have chosen optimized medication for angina with graduated exercise. Now here's the difference. He now believes, because he's had more of a discussion, that stenting does not reduce the risk of heart attacks. And his belief is correct. Stenting does not actually reduce the risk of future heart attacks. And that medication is actually very, very effective, almost in the same par as stenting for managing angina. So he decides, having done this comparison, yeah, with my situation I prefer the medication. So now he's dealing with his teenagers. Life's not perfect, but at least his life goes on. So let's look at Janet. Janet has poorly controlled asthma. And here's her beliefs. Asthma, not that serious, she thinks. Medication, she thinks, doesn't work if I use it regularly. And she has a very big fear of steroids, that it'll lead to weight gain, and very quickly. She's prescribed inhaled corticosteroids and long-acting beta-agonists. But because she has these beliefs, she hardly uses them. She doesn't say so, but she hardly uses them. In her experience, she's unable to get to the gym with friends because she knows that if she exercises, she'll get an asthma exacerbation. So this is her situation. What if, after shared decision-making, you talk to her in this situation about her goal to get to the gym, and you learn about, she learns more about low risk of the side effects. And it actually, with these two things, her goal of wanting to exercise and realizing that the steroids are not as high risk for weight gain, it leads to a new pattern of inhaler use. She has new motivation to use the inhalers. In her experience now, she finds she's able to go to the gym and her weight stays stable, even though she's using these inhalers much more regularly. And actually those beliefs come from this very interesting paper, The Patient Perspective of Barriers and Facilitators of Taking Long-Term Control of Medication for Asthma. And these people have developed a taxonomy for all the beliefs, reasonable or not, they exist in the patient's mind about asthma medication. So, how do we do shared decision making? Well, it probably needs more time to go into tremendous depth, but I've been working on this 3-talk model of shared decision making. It's team talk. First of all, make a team with your patients so that they know that you will be there to support this comparison of options. Give them some information about the options so at least they understand the trade-offs, and then ask them, tell me what matters most to you for this decision, the decision talk. This was published last year, I think, in the BMJ, and it's one I use for training. So how would you know? How would your organization measure shared decision making? Well, here I want to introduce a very short measure that we've been developing. Patient experience measure. I want you almost to answer this question for yourself right now. Think of a recent consultation you've had with a clinician and answer this question. How much effort was made to help you understand your health issues when you saw your clinician? You'll see the scale, no effort was made to every effort was made. You've got 0 to 9. What's your score? Second question, how much effort was made to listen to the things that matter most to you about your health issues? Again, 0 to 9. Every effort was made equals 9. No effort was made, 0. Last question, how much effort was made to include what matters most to you in choosing what to do next? So the maximum total score is 27. And I want you to put your arms in the air in this conference in Porto if anybody has 27. Look around, see if anybody's got 27. I bet you that not many people have their arms in the air. In other words, this is a very good discriminator of the kind of effort. So let me show you some scores from clinicians. Most clinicians score somewhere between 45% to 87% on attaining that 27 score. And here's 8 clinicians, and what you can see is that we collected their data using paper or SMS or IVR, and each clinician has a trend line, but the clinician number 1 there is the highest over all data collection modes. In other words, I think we have a way of collecting information from patients about how much effort was made to inform, to listen, and to include what matters most to them in decisions. And this measure is called Collaborate, and we're using it quite widely in some studies in the United States right now. So, what about this information? How do we get it to patients? Well, you'll maybe have heard about these tools called patient decision aids. They've been designed for patients to use accurate risk information in a way that people can understand pretty quickly. So one of the problems with these tools when they were developed 20 years ago is that they were over-engineered. They had just too much information, they took too long, couldn't fit them into the workflow. So more recently, people have been making some new tools, and we've called them encounter tools. And here's a clinician using a kind of tool like this with the patient. So they're both working on it together side by side. You could imagine maybe talking to your patient side by side with your desk. So here's one example of those tools called option grids, and I maybe just point your attention to this issue of a frequently asked question here. They come down the side, so it gives people permission to ask questions. And then there's the options, the lumpectomy with radiotherapy here, and mastectomy. This is for breast cancer surgery. So we'll read it by reading across, and this line has got which surgery is best for long-term survival. And you'll see surgery rates are the same, irrespective of lumpectomy with radiotherapy or mastectomy, which then leaves you to compare the other questions. What are the chances of cancer coming back in the breast, and so on. So we've just on the point of launching, I think, these new tools with EBSCO now. So we'll be making them so that you can choose the options you want to compare. Here's one for herniated disc in the lower back. You could choose those 3 options, make a grid at the point, and it would look something like this. You would compare 3 different treatment modalities. So these tools are available now for people to, I think they're brief enough to be used in the consultation. These are not these are not the only type of tools, and as a set of tools, they are helping to give patients choice awareness. They create a dialogue, and they give information to the patients just in time to make those comparable options. They hardly increase the encounter duration, because you have to give patients information anyway. You're just giving it in a more structured way. Do they lead to more health disparities? In other words, do people who are poor, are low educated, do they suffer when these tools are introduced? Well, the answer is, what do you think? And here's a question we asked. Do these tools reduce health inequalities? We did a systematic review, a meta-analysis. The answer is yes. The people who can gain the most, who are not well educated and who are not reading the quality newspapers and so on, they gain the most from using these kind of tools. So, very quick gallop over shared decision making. In my view, shared decision making has a huge potential to make patients more in more partnership with us, and to gain better health outcomes for the health system. People choosing wiser things that fit their situation. But I think it needs to be done exceptionally well. We don't want to give patients the sense of being abandoned to make difficult decisions on their own. Enjoy your conference in Porto. Thank you very much.